All right, it is 12 o'clock, so why don't we go ahead and get started? We are in an all virtual grand rounds today, which is a little unusual. We did this for a long time. It's been nice to be back in person, but really pleased to welcome Dr. Janine Young to give medical grand rounds today. I just want to have a little highlight. January 25th, we'll hear from Dr. Anna Jovanovich from the Rocky Mountain VA, giving us a talk on updates in nephrology. And then on February 1st, we're going to welcome Dr. Kirsten Lee Johansson as our 2023 Waldstrom invited lecturer. As a reminder, and as you can see on your slides there, all our medical grand rounds are eligible for CME and MOC credit. And so you can scan this QR code, which also went out to you in email. And we will take all of our questions virtually today using both the Q&A and chat features. And I know this is going to be an interactive talk, so you can look for opportunities to use the chat throughout Dr. Young's presentation. And now I really am pleased to welcome today's speaker, Dr. Janine Young. She is a professor in the Department of Pediatrics at the University of California, San Diego School of Medicine. And she is the new chief in the Division of Academic General Pediatrics, Newborn Medicine, and Developmental Behavioral Care at UCSD after a long time here at Colorado that we'll talk about in just a second. She did her undergraduate work at Columbia University, where she graduated cum laude. She was a medical student at Harvard University and then did her internship at the Boston Combined Program between Boston Children's and the Boston Medical Center before going on to her residency years at UCSF. She is a national and truly international leader in the care of and the health of children, specifically the focus on the health of refugee children and their families. She is a frequent invited speaker at the local, state, national, and international governmental levels, having given over 100 talks on related topics as local localities and whole countries look to her expertise as they decide how to respond to the ongoing worldwide refugee crisis. And it truly has been her life's work. As I was reviewing Dr. Young's CV last night, I noted that she gave her first talk on refugee health concerning Haitian immigrants at Guantanamo Bay in 1993. Her work has been incredibly well funded. She currently receives support from the CDC Division of Healthcare Quality, the CDC Division of Quarantine and Migration, the CDC Center for Excellence in Newcomer Health, the Department of Justice and the Office of Justice Programs, as well as the Colorado Department of Health and Human Services. And these grants really spread across a wide range of topics, including health equity data evaluation, novel approaches to healthcare outreach for Afghan communities, the screening of new Afghan arrivals through overflow clinics, issues surrounding female genital mutilation, general work on human rights for all immigrants, and justice for immigrants who have suffered crime against their persons. She does have a very long connection to Colorado. Several times in her career, her first faculty position was as an instructor in the Department of Pediatrics here at CU. She then took a faculty role at Yale University for several years, where she held a number of leadership positions, returning to Colorado, where she's been a leader in pediatric medicine as well as refugee health up until this past summer. She was very recently an associate professor of pediatrics here at the Colorado School of Medicine. She was the medical director of the Denver Health Refugee Clinic and the co-medical director of the Denver Health Human Rights Clinic and medical advisor to the State of Colorado Refugees Services Program. She was also a senior investigator at the Colorado Center for Global Health, an affiliate of the Center for Bioethics and Humanities, and an affiliate of the Eugene S. Farley Center for Health Policy. She has received a number of awards for her work. I'm realizing that I could go on for the entirety of her hour, so I'm going to stop now and really just say I'm very proud to welcome a very recent faculty depart, but someone who's very close to CU, Dr. Janine Young.
Thank you for that really lovely introduction, and I appreciate the warm welcome. These are my disclosures and acknowledgements. And I want to call out something rather obvious here, which is why a general pediatrician is giving you all a talk in internal medicine. And, you know, in pediatrics, we're always told that children are not little adults. And I'm sure you're often told that adults are not big children. In my roles advising the state of Colorado and running the Denver Health Refugee Clinic and the Human Rights Clinic, I was working sort of with all comers, including adults, and also continue to work on adult guidelines and recommendations for immigrant and refugee arrivals for the CDC. So that's my hat there, but I wanted to call out something relatively obvious here. So the goals of the talk today are multiple. One is to learn about what a lot of us would argue is the field of immigrant health through a case presentation. This is an area of medicine that has not been adequately taught that. And I really challenge you to start thinking about what in this is different than what you've seen before. We're going to review and understand that U.S. refugee arrival data. I'll present that, and that refugee is a legal definition. And we see it often used in the popular press as talking about any immigrant as being a refugee, and that is actually not correct, and we'll talk about that. We're going to review the approach to care for immigrant and refugee adults, including considerations around clinical, cultural, language, and care coordination issues. And then I'm going to share some evidence-based web tools and other resources to guide your medical screening approach. And then I challenge you to consider ways to approach immigrant QI and advocacy within your own hospital systems. So let's start with a case, because honestly, that's how I think a lot of us roll, which is we use what we see clinically to inform what we do from a QI advocacy and research approach. So this is a 20-year-old woman, we'll call her IA, and she comes in for a physical examination to you. She's studying business and accounting at a local community college. Her spoken English is quite good, but when asked, she says that she would prefer to have an Amharic interpreter on the phone to help her translate and interpret anything that she does not understand. So you get that interpreter on the phone. Unfortunately, it's not a rare language. So her chief complaint is need for a physical exam for community college. She also says that she's had lower back pain becoming more persistent with her running routine. She's gone to a couple local ERs, urgent cares, twice for the pain and was prescribed ibuprofen for lower back pain. And she recently read about female genital cutting and wonders if her mother had her cut when she was young. This is all in your 20-minute visit, by the way. Has medical history. She was born in Asmara, Eritrea. She was orphaned due to war. She was followed by various providers over the years with no known issues. She has no hospitalizations, surgeries. You ask her if she's had any blood transfusions overseas, and she says that she doesn't know of any of this. She says that she's taking 200 milligrams of ibuprofen every 8 hours when she has back pain, and she's not using any home remedies, something that is important to ask people coming from different countries. She has no allergies. And then you ask her family history. And I think family history is a pretty dubious question and difficult to interpret and explain in other languages. And the way I've sort of developed this over time is being as concrete as possible. So I ask something like, is there any history of medical issues in your family? And what I mean by that is, do you know if your parents, siblings, grandparents, uncles, aunts, or cousins have any current medical problems, or have they ever had any medical problems in their lives? So this is the question. The answer is no. Social history, she lives with her maternal aunt since US arrival and with a younger brother who came to the US with her. She's not traveled back to Eritrea since her arrival at age 10 years old, so she's been in the US for 10 years. Her aunt works in childcare. They have Section 8 housing, food stamps, and she feels a lot of pressure to work more and finish school. LMP was a week ago. She's got regular monthly menses and sexual history. She's not sexually active and wants to wait until she's married. So the first question I have for you all, and you can put this in the chat, is what other history do you want to get? And I think that Meryl was going to read out any questions that come up. What else do you want to know about her?
Still waiting for comments. Oh, someone asked about if she knows if she's up to date on her childhood vaccines, is a question.
That's a great question. She's been going to school, and so she is up to date on her vaccines. And I think, but this gets at a good question, which is, this is an example of someone who's been here for 10 years as an immigrant. Many of the folks that you're going to be seeing and have seen in the emergency room, urgent care, in the hospital, and in your clinics are new arrivals. If it's a refugee, which is a legal definition, they should come with vaccine records. If it's any other form of immigrant, most of them will not have records unless they happen to bring them with them. And so for her case, yes, she has had her vaccines and they're all up to date. What other questions?
I have a question, is if she's been screened for tuberculosis ever?
She's not really sure. She came when she was 10. She actually doesn't know. And it's a great question. So it sounds like something that we would think about doing. What else? If nothing else, I'm going to go on. Meryl, any other questions? That's it for now. Okay. Thank you. So again, I'm a pediatrician, so this is where I get most of my materials, and this was published in American Academy of Pediatrics, but it's sort of, giving an example of what a comprehensive history looks like for someone who is coming in as an immigrant to the US. And so I put some stars in the ones that are really relevant. You know, immigration information is really important in terms of also just migration history. It's clearly not something you're going to ask when you walk into a room with a patient. It can be pretty frightening and scary because people don't know what you're going to use that information for and how you're going to write it in the chart. But I think it's incredibly important to figure out, you know, where are you from? How did you get here? We've had cases here in San Diego. We have cases in Denver. We've seen many times where you get histories of someone who came from, say, Somalia, went to South Africa to work to gain enough money, and then bought a one-way ticket to Brazil, gets to Brazil, and then walks and, you know, takes trains and buses and hitchhikes all the way to the southern U.S. border. And so, you know, from a exposure, environmental exposure risks, from an infectious disease standpoint risk, you could say, you know, de novo, someone's from Somalia and they have certain risks there, but boy, does it change things when they also travel throughout South America and Central America. You know, I already asked in the history about overseas blood transfusion surgeries, traditional cutting. These are things that you really need to consider, you know, around bloodborne transmission, Hep B, Hep C, HIV. I think it's very reasonable to think about that. Nutrition histories for people who are just showing up. We see micronutrient deficiencies are incredibly common, you know, anemia, et cetera. Environmental exposures, we'll talk about in a little bit, but lead being a big one. Mercury is a problem as well. I put a star next to treatment prior to arrival. And I think this can be interpreted in different ways. And I'm going to go through this in a couple of slides. But if you're a refugee, there are treatments that you get overseas before coming to the US, and they're standardized. But they're also, when people come to the US as a refugee, let's say you arrive in Texas first, you have a domestic medical screening examination and their treatment's done then as well. And so people will be able to tell you, they'll remember if they were recently treated. You know, someone who's been in the US for 10 years, I think that's a little bit difficult. And then if it's you know, an asylum seeker, they're not coming through the refugee program, the likelihood of them having any kind of standardized treatments is pretty much nil. And so that's something to keep in mind. The other thing that I just have an arrow here is to think about is literacy level. I assume that many of you are seeing many Afghan arrivals. There were 2,000 who were evacuated to Colorado when the Taliban took over Afghanistan. They all started coming in October of 2021 through June of 2022. Most of the women are pre-literate. They were not allowed to go to school. Many of the men worked for the US military and are either fluent in English, or many of them also speak multiple languages, and their wives, unfortunately, some of them cannot read letters or numbers. So it's really important when you're providing medical information to make sure that what you're giving them, an AVS from Epic is really not worthwhile. And how are you going to give health information, and how are you going to document in the chart someone who is pre-literate and can't read numbers? And this is a challenge, I think, for thinking about systems changes in Epic and standardization of this kind of data collection down to that level so that people can quickly see that someone is pre-literate. Okay, so IA, I've told you, came to the US 10 years ago. How do we know if she's a refugee arrival and why do we care? Does anyone know? And please put anything in the chat. And this is always really hard since I can't see people's faces and have people raise hands.
No comments yet.
Go ahead. Nothing yet? Okay. Why do we care? So
I have someone who says her documentation would reflect it, or availability of health insurance.
yep. Okay. So if you're, that's right. So if you're a refugee, it's a legal status in the United States, and it confers Medicaid, which is no small thing. And I would say probably about 98% of refugee arrivals will qualify for Medicaid. There are very few will come over with enough money to make it so they don't qualify. But it's important also because there are systems in place in Colorado and all states that provide supports for refugees. And also there are medical records that you can get from screening overseas. And so I think this is incredibly important to know because you can understand what happened, how they got here, and the types of screenings that happened. So one of the big questions we all ask and hope and pray that people will hand over medical records, and most often don't, is when you're seeing a new patient is, do you have any prior medical records? The other question to ask is, do you have an IOM bag? So when you are seeing patients in the ER who are admitted to the hospital in the emergency room, they can be new refugee arrivals. They will all be carrying this International Organization of Migration bag. I don't know how many of you have seen, if you start looking in airports, you will start to see this. These are all people who have just been flown from refugee camps or cities to the United States as new refugee arrivals. This is it. And so with the Afghan crisis and going through DIA, I can't tell you how many times there were large groups of people with these bags. What these bags contain are their medical records from overseas, okay? All right, so ask any newcomer if they're a refugee and they'll know. It's a long, many-year process from acceptance to arrival in the US. It's important because there's overseas prior medical workup, screening, treatment records, and vaccines. They also have access to resettlement agencies and state contacts for early supports. And you can also get record requests from your Colorado state contact for results from the standard domestic medical screening examination. This is the link for all state refugee health coordinators. So you get someone who shows up, they said they just got here from Texas. You go there, you call the state refugee health coordinator in Texas, and they can get you the overseas records. And this compares to an immigrant, not otherwise specified, a migrant, an asylum seeker, someone on a diversity visa, green card lottery. None of these folks are having these evaluations overseas. And the question also is, why not? And why would you treat these patients differently? The answer is they shouldn't be. Okay, so what is a refugee? It's from post-World War II. It's someone who's unable or unwilling to return to their country of origin owing to a well-founded fear of being persecuted for reasons of race, religion, nationality, membership of a particular social group, or political opinion. What it buys you is the list on the right. It's a legal designation. There's a path to US citizenship. You're Medicaid eligible, WIC eligible. You're assigned to a resettlement agency that provides newcomer supports for a limited time, including help acquiring housing, all the social determinants of health, help learning the transportation system, transportation to the initial domestic medical exam, language classes, and link to school and work. Okay, I think this is really important because most of the social workers and nursing staff with whom you guys work do not know this either. And so the question is how do we unsilo this so people are able to start linking with the organizations that are in Denver and in Colorado and in the country so that there's more communication. I think the siloing is a chronic issue. I'm not going to spend a lot of time on this, but this is just a snapshot of demographics. And it's one of my favorite slides because it really goes through the geopolitical issues that have happened over time and how that has influenced politically our refugee resettlement. And it goes back to the 1970s, post-Vietnam. And you can see these, ceilings of refugee admission. 1980, we had over 200,000 refugees accepted to the United States. And it's changed drastically over time, with the World Trade Center bombings. With the Trump administration, I think that's the elephant in the room here. As you can see at the right-hand side the refugee resettlement is determined by the President of the United States, the number accepted into the United States each year. And President Trump gutted the program. And because it's multiple systems, both overseas and in the US, everyone lost, there were no refugees coming in, therefore everyone lost their jobs. And so what it's happened is the downstream effect is that we're still not able to catch up with getting more refugees admitted. So for example, for fiscal year 2022, with President Biden is in office, even though his ceiling was 125,000 people, he was only able to get 25,000 into the United States. Okay, this is just another slide showing in the blue, the line is the annual ceiling determined by President of the United States and the actual number of admitted refugees. And so again, for fiscal year 2022 and 23, we have 125,000 we'd like to admit. We'll see where we get. And just if you're wondering what's going on in Colorado, this is just for this fiscal year, just these first 2 months, October and November. We've only had 110 total into Colorado, and you can see where they're coming from. So Democratic Republic of Congo, Eritrea, Burma, Afghanistan. Afghanistan, most of the folks who came with the evacuation do not have refugee status. They're humanitarian parolees. That is a complicated issue that is still being discussed federally as to whether they're all going to be granted legal status to stay in the US permanently. So what happens to refugees overseas? And in the case of the patient that we have that we were talking about, the 20-year-old, when she came here when she was 10 years old, what happened to her is she was a refugee from Eritrea, was in Ethiopia, was in a refugee camp there. She was accepted into the United States. And once she's accepted into the United States, which is a multi-year process, the International Organization of Migration, WHO, are funded by the US to do overseas medical examinations 6 months before departure on all refugees, screening them for inadmissible health-related conditions, including active TB. If they are diagnosed with active TB, which is quite common, they are treated overseas so that they complete 6 months at least of treatment, depending on the type of TB they have, etc. 3 weeks before departure, they're retested. And then 24 to 48 hours before departure, all refugees get presumptive treatment for strongyloidiasis with ivermectin, soil-transmitted helminth infections with albendazole. And if you're from sub-Saharan Africa, you're getting praziquantel for schistosomiasis. And if you're also from sub-Saharan Africa, you're getting artemether or lumefantrine for P. falciparum malaria. So the question I ask you all is, why are we doing that for this group? And what is happening for all the other immigrants, an Eritrean or Ethiopian immigrant who's coming to see you in the ER, who is not a refugee, does not get any of this. So you need to think about what the implications are, and I'll provide some data as to why this is being done. Okay, so the other things that happened for our 20-year-old patient is that overseas, and this gets to, the screening that was done by the IOM physician, and this is on the paperwork that you can access by contacting the state refugee health coordinator, is they all get tested with an IGRA if they're 2 to 14, or a skin test. They're only looking for active TB. They're not dealing with latent TB. Everyone's getting a chest x-ray if they're 15 and up, specifically looking for active TB that could be spread on a commercial airline when you're flying a patient over. Everyone is being tested for hepatitis B. Think about that. the vast majority of countries where immigrants and refugees are coming from, which is really resource poor areas of developing countries, hepatitis B has intermediate to high prevalence. Okay, this has only been done since 2018. Okay, if negative, they're vaccinated. They have initiated vaccines. They're getting tested for gonorrhea, chlamydia, syphilis if they're 15 and up. Of note, HIV testing hasn't been done since 2010 because of the real stigma associated and concerns, and that there was fear that they would not be allowed into the US if they were HIV positive. They get a past medical history checklist, a full physical exam, and then the presumptive treatment that we talked about. And they also come with vaccine records. There was a question earlier about what vaccines, or do they have vaccines? This is the list of vaccines, but the caveat is, you can see in the title here, depending on availability and eligibility. What I will tell you is that EPIC is not designed for newcomer adults. The presumption in EPIC nationally is that everyone is US born and that you've had your entire primary series as a child. And this is a huge issue right now that we're looking at actually and publishing on. So if you have an adult immigrant who's coming in and who has no vaccine records, they need to get titers and or they need to be vaccinated. And this does not happen, is not happening standardly at Denver Health, is not happening at most adult hospitals and clinics nationally. And it's a flaw in EPIC, frankly. Okay, so what are the caveats with this overseas evaluation? They do a full physical exam. It's done by usually a family med physician with 2 to 5 years of experience, usually doesn't include a GU exam. There's no formal hearing done, sometimes vision. If there's significant medical issues, the patient is treated and stabilized. Contagious diseases are treated to assure no issues on the commercial flight, but diagnoses get missed. We had someone put on a flight with a diagnosis of a dissecting aortic aneurysm who ended up in the ICU as soon as they arrived at altitude. So patients and families are worried that if there are significant medical issues discovered, it can delay resettlement. So they might not share information with IOM, and this happens actually quite a bit. IOM now actually takes altitude of US destination, AKA Denver, into account and doesn't resettle refugees with relevant diagnoses to cities at higher altitudes. This was not done when we first started. So we would have sickle cell patients coming and then going to crises. The only reason they will do it if there is already family there. So how can you get more information? And I would really encourage you to share this with your nursing staff and social workers. So this link at the top is the state refugee health coordinators. This is a screenshot for Colorado. Your contact is Maki Gaboro. You can call him, you can email him. He can get you these records that I have screenshotted here. And then there are relevant resettlement agencies in Colorado, or International Rescue Committee, ACC and LFS. IRC also has funding to support refugee arrivals in crisis and using substances, domestic violence. Your social workers probably do not know this. So again, it's unsiloing all of these different services so that you are not completely overwhelmed with patients and social work and just discharging them. Okay. So let's get back to this case. What we know so far is it's a 20-year-old who's been in the US for 10 years. She needs a physical exam and she's got some lower back pain and she was seen in the ER. What else do you want to know?
Somebody mentioned, she brought up if she had been had genital cutting before, and so making sure she gets a safe GU exam.
Yep. And how comfortable are you guys doing external genital exams in women? How often do you do that for a physical exam? Because female, oh, sorry, go ahead.
Oh, I think most folks are comfortable doing an external genital exam in the absence of something like cutting, but I'm not sure many folks would have seen what cutting scars or a history of that would look like.
Okay. Yeah. And I think this is important for multiple reasons. So she, if she's asking if she was cut in Eritrea, and it depends on where this is practiced, and I'm not going to give a whole talk on FGC for this talk, for this meeting, but there are 30 countries where FGC is practiced. Eritrea has very high rates. The question is do you do it or do you refer to OBGYN? I can tell you a lot of your OBGYN colleagues probably have seen it at this point. And so it's just something to think about is when, where, how. She was cut, if she's asking, she doesn't remember. So she was cut at 4 or under. And it's very, very common for women to not know if they were cut because the parents often will not talk to them about it. And so sometimes you'll see patients and you'll do an external exam and you will see this and they have no idea they were cut. Other questions? Other exam findings? I can just skip to it. We'll just go through this. So this is pertinent positives and negatives only here. So she's brand new. You've never seen her before. If this was a new arrival, you want to check vision and hearing. We're seeing immigrant and refugee arrivals who've been fleeing war-torn areas, Afghanistan, bomb blasts with hearing loss. They might not know. It's just incredibly important to do. And the disability associated is significant. This patient looks great, really nothing. And, you're looking for head to toe, anything and everything, particularly more with recent arrivals, thyromegaly, cardiac findings, et cetera, because for most part, many of these patients have never been examined. If they're coming from refugee resettlement, again, stuff gets missed. We've diagnosed adults with partial coarced aortas and hypertension, anything and everything goes. In her case, she's got some, mild back pain. She's got no CVA tenderness. She's got some moderate paraspinal muscle tenderness and L1, L2. She doesn't have an antalgic gait. Her neuro is totally normal. And her external genital exam is normal as well. So she was not cut. So just very briefly, and this is a slide from colleagues in Belgium, so excuse the French literally here. This is the prevalence of female genital cutting. Think about all the patients that you guys see in the ER, again, in every setting where you're working, and think about patients who probably had FGC that was missed, okay? So the red is the most common. Egypt has very high rates of FGC, Somalia, Eritrea, Mali, Burkina Faso, a lot of West Africa. But also I want to point out India has limited prevalence in the Dawadi Bohra community, Pakistan, Iran, Iraq. And then you can see, North America is highlighted. And the reason is because we have all of these immigrants who are coming here. Most of the FGC is practiced overseas. There are case reports, and there was a whole DOJ investigation of FGC being practiced by an emergency room physician in Michigan. I don't know if Dr. Chopra, I'm assuming, I think you came from Michigan, so probably know very much about that. But the question is if women don't know they've been cut, whose job is it to diagnose them? Is the menstrual pain from, obstruction, because there are type 3 FGC where there's, closure of the external genitalia. And so this is a whole other talk, but I just wanted to at least share this data with you. Okay, so let's go back to the case. 20-year-old former unaccompanied refugee minor from Eritrea arrived in Denver 10 years ago and had some unknown studies done through her domestic medical exam done when she arrived. She presents with chronic lower back pain with a normal neuro exam and also has visited a local ER 2 times for the same issue, was given ibuprofen, but misunderstood the correct dose to take. So she was taking 200 milligrams. She's concerned that she had FGC, but your examination shows no cutting was done. She's in office. And it'll be difficult to track down all of her records done 10 years ago. And, 10 years ago, Denver Health had scan written records at the time. So what do you want to do? Do you want to do any labs? And then please provide some thoughts about how much of a workup you would do, if any, if this was a new immigrant versus a case like this one, where she's been here for 10 years. Is there any difference? So tell me what studies you want to do. or if you don't.
I have votes for even just starting with a CBC, if this is related to heavy periods and she has resultant anemia, iron studies. Some votes for some of her immunization titers, and that might be more important for a new immigrant versus an old.
Mm-hmm.
What else, folks?
Anything else?
I think you made a great point, Dr. Young, that immigrant is the umbrella term and refugee is a more specific term. And so determining, in this case, we sort of know this person, but I think we would do different things depending on their status, as you said earlier.
Mm-hmm. Unless you can't track down their records, which is always sort of tricky. And I think we're always sort of up against this with not having universal medical records, is how likely am I going to get records back? And then the game of, not doing financial harm as well. So how do you tier things? And this is the game I think we all play. Okay, so you're in the office, you're stressed, you have your next patients are coming. So this is an in-office user-friendly tool that you can start using. This is being developed with CDC and the Minnesota Centers of Excellence funding. So you can Google CareRef, it's the first thing that comes up. I'm screenshotting it. You can see on the left, you just click Start CareRef. You put in that you're in Colorado. She was from Eritrea. She left from Ethiopia. You put in her date of birth, etc. And then magically it gives you all the recommendations. And this is quick and easy to do. You can click on these things and it toggles back to CDC domestic refugee screening guidelines. So again, I think it's challenging in this case as to what you do. She's been here for 10 years. Let's pretend she's a new arrival versus not. I think a CBC and DIF is absolutely reasonable. DIF, even in her case, looking for chronic eosinophilia from an undiagnosed parasitic infection, possible. Some providers do get UAs, specifically looking for hematuria because of schistosomiasis in a sub-Saharan African, and we'll talk about this a little bit as a marker for schistosoma infection. Lead testing, I challenge you to think about this. Newly arriving immigrants who are pregnant or breastfeeding should be tested for lead, period. This is the recommendation through ACOG and CDC. I don't know how many of you are familiar with this, but it's really underutilized. Denver Health, we got with the Afghan crisis and the ubiquitous elevated lead levels, got them to add lead to prenatal testing in women who are pregnant. But I would really challenge you to start looking at this. We've had many levels that have been quite elevated. TB kind of goes without saying. I think most of us think of TB when we're seeing a new immigrant. Hepatitis B, hepatitis C. Let's talk about this a little bit. This patient was born in a developing country where prenatal lab testing, she was probably a home birth. Even if she wasn't, prenatal lab testing doesn't happen ubiquitously, and it's also kind of ad hoc. And so she either has vertical transmission or horizontal transmission until proven otherwise. And we'll talk a little bit more about this. This is very underdiagnosed. I would argue it's a neglected tropical disease, frankly. And we've seen many cases that have been missed. And the part of the problem is a silent infection for the most part, and you don't present until things are bad. Hepatitis C, obviously she's an adult, so she should be tested. But even as a child, we don't have any family records of her. We don't know the parents' risk factors, so she should be tested. Soil transmitted helminth infections for a new arrival, and I'll present some data on this, is so ubiquitous in new arrivals that, that refugees get presumptively treated with albendazole overseas, or you can get OMPs once they arrive. Strongyloidiasis is ubiquitous, and I'll present data on that, and schistosomiasis is also ubiquitous, okay? Again, vertically or horizontally transmitted syphilis, and the rest is here. Okay, so that comes up in CareRef. So these are her results. So she has normocytic anemia. She doesn't have eosinophilia. She's got IGRA positive, and miraculously you get your chest x-ray immediately and it's negative. She's asymptomatic. And these are the other tests. She's got strongyloidiasis and schistosomiasis with no symptoms. So what do you want to do? Where do we go from here? What treatment, studies, interventions do you want to provide, and what kind of follow-up? And please put your thoughts in the chat. Meryl, we getting anything?
Nothing.
Okay. Man, it's hard to do these talks over Zoom. I'm sorry. We're gonna keep going. So why do we screen immigrants for bloodborne infections? Okay, in general. So this is from WHO. This is the proportion of healthcare injections given with reused equipment by region. So Middle Eastern, Mediterranean Eastern region is upwards of 15%. I'm not kidding. Southeast Asia, over 5%, et cetera. And you can kind of see here. We've seen this. I had a 16-year-old who'd had multiple surgeries in Pakistan for cleft lip palate, who had Hep C, and we just tested her. Would have been missed if no one thought about it. Really start thinking about these things. Why do we screen immigrants for vertically transmitted infections? Hepatitis B is, intermediate to high prevalence in most countries. 65 million women of childbearing age are infected, and in 2016, only 10.5% were aware of their infection. Okay. This is a map just showing, for those who are geographically challenged, I have a nice little arrow here showing you where Eritrea is, and these are countries most affected by hepatitis B. So start thinking about all the patients that you've seen who are from these areas who weren't tested. And these are all vaccinated folks. They came to the US, they got their 3 hepatitis B vaccines, but they were already infected. Here's hepatitis C data. The other question is why are we presumptively treating with albendazole or sending OMPs with refugees who arrive in the US? This is global prevalence of soil-transmitted helminth infections, ascaris, whipworm, and hookworm. This is a meta-analysis looking internationally. It is incredibly common. And because of this was the landmark study that was done by colleagues at CDC looking at albendazole therapy and enteric parasites in US-bound refugees. It was looking at over 25,000 refugees arriving in Minnesota. And the blue, light blue column on the left shows when arrivals were coming with no albendazole treatment before 1999 and what the prevalence was. And after the ubiquitous albendazole treatment was started, with decreased rates in the upwards of 90-something% in ascaris, hookworm, and somewhere around 50% in whipworm infections. And this is why it's done. We'll talk a little bit about strongyloidiasis. Strongyloidiasis is throughout all developing countries. I think the key here in this lovely diagram is it's the parasite burrows into the skin. So you have to have, skin contact with contaminated soil. But the key here is that the phenomenon of strongyloidiasis is autoinfection. So once you have it, you can continue where you see number 10 to 7 is you continue to reinfect. And so there have been case reports of patients who came to the United States 50 years ago who still have the infection. And why do we care? And this is why we care. So strongyloidiasis hyperinfection syndrome, albeit not very common, has a mortality rate of upwards of 50%. There have been several case reports in New England Journal of Medicine. This one was in a 47-year-old man who had lived in Laos, who was on prednisone for dermatomyositis. There was another case report in New England Journal of a man from Dominican Republic who was put on a steroid burst for 2 weeks for a nickel allergy, who ended up in the ICU. And then, question to our colleagues in the ICU who are giving steroids for COVID, as well as checking strongy at the same time and treating. Schistosomiasis is also very common in sub-Saharan Africa. In this case, the most common are Schistosoma mansoni and hematobium. Schistosoma mansoni is associated with liver fibrosis and portal hypertension. Hematobium is associated with squamous cell carcinoma and urinary tract obstruction and renal failure. And this is the life cycle of for schistosomiasis. Also, it's skin exposure to contaminated freshwater sources, so like rivers, streams where people are washing, bathing, doing laundry. And then the schistosomiasis prevalence data that there was in Minnesota, a look at a serum bank from Somali refugees, and over 80% were positive. There was a study from the Lost Boys of Sudan in 2004. There were case reports of chronic abdominal pain in boys. So they were tested for schistosoma IgG, and 44% were positive, and 46% were positive for strongy. The final thing I'll talk about is lead. As I said, any female who's pregnant or breastfeeding should be tested. These pictures are Afghan kids using coal makeup, which is very, very common. It's mostly lead-based and it absorbs into the skin. So if you're seeing Afghan arrivals, women with coal makeup, ask and make sure that it's cosmetics bought in the United States. Spices are very common for elevated lead levels. This is just more information on lead, just to give you an idea of how common this is. And these are the countries here that still use leaded gasoline, which includes Afghanistan. So there are 6 countries still using leaded gasoline. This is a huge underdiagnosed problem. So back to the case. A 20-year-old Eritrean, former unaccompanied refugee minor, arrived in the US 10 years ago. She's got a normocytic anemia, normal menses, a positive quantiferon, negative chest x-ray, worsening lower back pain with moderate paraspinal muscle tenderness. She got a lateral x-ray of her spine and a CT. What does she have?
So some folks actually got this a few minutes ago and said Pott's disease.
Nice. Okay, very good. So, I mean, what you see here is collapse of vertebral bodies. You see lytic lesions. There was, when this patient was worked up, there was actually concern for neoplastic causes as well, so was admitted. So yes, this is Pott's disease. So it's in 1 to 5% of TB patients. It's 10% of extrapulmonary cases. It's MTB. It's hematogenous spread to the bone. It's insidious, progressive back pain, and symptoms can be from months to several years. It's local pain. You have the, in this picture here, you have the gibbous deformity. Diagnosis is MRI, AFB, and then management I have listed here. So the outcome is she was followed closely by Denver Public Health with directly observed therapy for Pott's disease. Ortho at Denver Health managed her and followed her pain. She was also treated for with ivermectin for strongyloidiasis and praziquantel for schisto. And then there was an astute medical student on a sub-I who found her scanned, hardly legible written Denver Health records from her domestic medical examination performed in 2003. And the only studies done at the time showed a negative skin test. My question for you is why? HIV negative, microcytic anemia, negative ONP. And in the assessment and plan, it said moderately malnourished 10-year-old refugee with iron deficiency anemia. And so you can see that there were a lot of studies that weren't done during that time because the guidelines have changed over time. So you can't guarantee that just because you have a refugee, they had all their tests done and that everything was taken care of. The question I have for you is, why was her initial skin test negative? And can we go on one skin test?
Got someone who asked if TB vaccination is done in Eritrea, since that can confound the TST test.
Yeah, so Depends. BCG is often given at birth, but if you're a home birth, you're not going to get it. And it really varies greatly on your access to healthcare. Afghanistan, for example, we did a literature review looking at what's standardly done, and there are many areas that just don't have access to healthcare at all now, worse with the Taliban. Even if this child at 10 was vaccinated with BCG at birth, it only protects against newborn disseminated TB, like miliary TB and TB meningitis. And in this case, it would confound and make more likely make a false positive. And given that she's 10 years old, it's pretty unlikely to get a false positive TST from BCG given at birth, because it's a pretty long time since BCG was given if she had it.
I've got another person who's wondering if malnutrition or the parasites can suppress the TST response.
Absolutely. And that's the presumption, is she was positive to begin with and just sort of had just kind of percolated over time. And so the moderately malnourished, I think the bottom line is anyone who's immunosuppressed in any way, has a new diagnosis of diabetes, whatever it is even if your IGRA is negative, or, you know, for you guys, you're all doing IGRAs, it can be false negative and just be blunted with energy. And so if you always need to think TB. And so that's the answer to that. So food for thought. Immigrant patients have some unique needs, exposure risks, diseases, and systems barriers to care. Ask questions that are specific to immigrants, including obtaining detailed travel histories and environmental exposure risks. And how can each of you look at your health system and begin to address immigrant systems barriers for your patients? Some things that are happening at Denver Health that we're going to be doing out here at Rady Children's is systematization of race, ethnicity, expanded ethnicity, language, birth country data. So Denver Health, we got to do this universally so that we can look at subpopulation data and say, instead of saying someone's African American, they're Somali, and you can start looking at subpopulations and seeing COVID vaccine uptake rates and what kind of public health measures or QI efforts you can do to increase vaccination, for example. Looking at your language service access and you know, where language is pre-booked standardly, developing immigrant laboratory smart sets and encounter text so that it's easier for you to order these things. And we built that at Denver Health and are going to be building it out here. Visual teaching materials for pre-literate patients is huge, and standardizing that, and then developing a really robust culturally matched care navigation program, I think, is important. And the other thing I'll leave you with is, you know, most inpatient and outpatient providers are not aware of guidelines for medical screening of immigrants. So how will this talk affect how you provide care for immigrant patients? Just something to think about. And then finally, if you're really interested in this, I'll highlight a couple things. There are links to the domestic refugee screening guidelines and Care Ref. NRC RIM is a center that has lots of online education materials in different languages. And then the other thing I'll say is that there's a Society of Refugee Health Providers that you can join that is a really good group of people, multidisciplinary from all across the country and actually world, who come together for the North American Refugee Health Conference that's going to be held in July in Calgary, Canada. And that's it. So thank you, and I'll stop and see if you have any questions.
Dr. Young, thank you very much. It was excellent. And despite the quiet audience, which happens on Zoom, there are actually a lot of questions. The first one, so Dr. Zeppler is on, and he was noting, thank you for the great talk, but also noting that, you know, he doesn't see the issues you're talking about publicized on a regular basis, including through the American Academy of Pediatrics. And I think it gets to your last point, which is, you know, how does one remember all these things when they need them? So what is being done at the national level to publicize this in terms of newsletters, highlights, and other resources that people can turn to when they run into these questions?
Yeah, that's a great question. I think this gets, again, back to the siloed nature of everything that we do. One thing is on this list, the Minnesota Center of Excellence in Newcomer Health, the link is here, has really become a resource for education. around these issues. And so there are webinars on there. There's prior recorded talks that you can access at any point. The Society of Refugee Health Providers also has webinars, but again, it's sort of asking people to kind of go that extra step. University of Colorado is also hosting, and I should have put this on here actually, an ECHO series on immigrant health with the Minnesota Center of Excellence. And so we've done talks on Ukrainian arrivals, Afghan arrivals, and general overview. And there's a list of about 10 more topics that are coming up on, everything from Hep B, getting experts in Trop Med to talk, et cetera, et cetera. So that's something else to look at. I think there's a fine line, and it's really difficult, and a thing that I find really challenging with, how much do you put also in the popular press because of xenophobia and backlash. We've seen this happen with TB. You see this actually with Title 42, which is, President Biden has continued Trump's decision to use a antiquated CDC ruling to keep adult immigrants out of the US because they are a health risk for COVID, which is not accurate. And so, how much do you say, these things need to be screened for? And then what do you do when this gets into places like Breitbart News who say everyone has TB? So I don't have a great answer for that. So if any of you come up with anything, let me know.
No, it's a sad and great point. Can you talk about opportunities? I know you are recently have left Denver, but I'm sure you still know the answer to this. Opportunities for people to volunteer in refugee clinics, in resettlement, in acceptance into the country, et cetera. What can people, both in medicine and pediatrics, do here in Denver?
Yeah, so there are the 3 resettlement agencies. International Rescue Committee is a good one to contact. And I think, everyone's quite overwhelmed still with just, again, everything having been gutted over the past, with the Trump administration. There are some other nonprofits in the area. Project Worthmore was doing emergency resettlement of Afghan arrivals. So it depends on how much you want to get involved. You can help with resettling a family. You can adopt a family to kind of get them through, the initial part of resettlement. So I would contact the resettlement agencies. In terms of the refugee clinic, there are rotations that are being built. There's an immigrant health elective. That's a month-long elective that you can do and contact the Denver Health Refugee Clinic providers, and you can rotate in for a month. And that is for really anyone in, internal medicine, OBGYN, et cetera. I think those are probably the best ways at this point in Denver.
There's a specific follow-up question from one of our primary care leaders who asks about family screening for schisto and strongyloides in the example you gave. So if you found that the 20-year-old person living in the home has one or both of those diseases, do you screen family? Is there in-house transmission?
Not so much. So it's a great question. The answer is no, but the presumption is if they came from Eritrea, they probably have it too, because they were doing the same things, and it's a chronic infection. And so we have had, this was very tragic, and these are the cases that, you sort of carry with you forever, but I had a family of 5 from Sudan who were non-refugees who came through the green card lottery. So you win the lottery, there's like 30,000 of these visas that are given to countries that normally people don't get to immigrate to the US from. And so the father was in his early 40s, died of a massive GI bleed. And no, a postmortem wasn't done, but every single family member had schisto. So the presumption is, I think he had schisto Mansoni. And so we treated everybody else. But again, these are neglected tropical diseases that we just have not been taught to even think about. And I think it's very different than global health, right? It's health in the United States.
Yeah. There's a question, and it sort of combines that intersection that you were getting at of health and politics. But the question is, the definition of refugee that you showed makes no mention of how someone comes to a country. It only is about the person's feeling when why they left the country of origin. How do we get away with not calling everyone a refugee and dividing people into other categories with lesser services?
Oh, that's a great question. I mean, I mean, it's the refugee is a political designation. It's a complete, it depends on the president. It depends on what the favored countries are. Haitians don't get refugee status. It's people, Central Americans mostly don't get refugee status. Mexicans don't ever get refugee status. There's a law, federal law that says if you're Mexican, you cannot get refugee status. I mean, it's very difficult to do it. You can, but it's hard. And I think it gets down to the wording, the legal wording of refugee is that, people argue, well, Haiti, the government isn't, targeting a specific group because of ethnicity or religious beliefs or gender. It's just all difficult. Therefore, they don't get refugee status. I mean, most of my Central American patients from Guatemala, El Salvador, and Honduras cannot get refugee status. So, I mean, I don't have an answer to it. I don't agree with it. And I think right now, Western Europe does a pretty lousy job of this as well, and significantly limits where people are coming from. It's a big issue. I can't answer it.
Yeah, no, that was a great start, though. I appreciate it. It is 1:01, so I think we will have to end things here, but I know there's a number of other questions. Thank you so much for this inspiring talk and for willing to come back to us virtually.
Absolutely. Nice to see you.
You too.